I'm Dr. Jyoti Bajpai. I'm the lead for medical and precision oncology at Apollo Groups of Hospitals, Navi, Mumbai, Maharashtra. I'm also a senior consultant at SRH and Reliance Hospital, Mumbai. So today I'm going to discuss with you about the recently conducted ABC 8 guideline meeting, and I was privileged to be the country's voice there. And I would really like to say that, these guidelines are very unique, very different than any other guidelines, because these are patient-centric guidelines. Patients are at the central stage. So it is not only the clinicians and researchers, but there are patients, survivors, patient advocates who put together they brainstorm together to reach to a consensus. And this ABC 8 and Global Alliance meeting, these are highly prestigious, highly valuable, and I would like to really say that Dr. Fatima Cardozo, who's the president for Global Alliance, the mission behind these Global Alliance and guidelines is that, it is not only that we should bring more and more molecules and drugs in the armamentarium, but we should also ensure that whether these important life-saving drugs are reaching to masses, and what are the strategies, how can we combine together, how can we join hands and try to really make a progress in advanced breast cancer patients' lives and every patient's life beyond geographical or political boundaries. So that is the very essence of these very important guidelines and alliance. And as we know that, advanced breast cancer is practically important. Each and every country, it is the major cause of mortality and morbidity in almost all countries. Only in very poor countries, still the cervical cancer is predominant. Otherwise, practically everywhere it has taken over. So it is very important, and by providing holistic care, we can actually improve the lives of these patients. So that is the very essence, and which is again being discussed, underscored by this alliance meeting. There were a couple of definitions which were discussed, redefined. For example, endocrine resistance, endocrine therapy resistance. What about the secondary endocrine resistance? And the new terminology was added, like early acquired resistance and late acquired resistance in this orbit, which is defined by less than 12 months of endocrine therapy and then failure, versus more than 12 months of endocrine therapy and then failure. And these are important because they practically decide that how the further line of endocrine therapy may benefit to these patients. There are a couple of options, couple of molecules in the armamentarium, and depending upon what drugs patients have been exposed before in end-to-end, or whether this is a de novo situation, what kind of disease we are encountering, that really gives us a choice that how we are defining our therapy. Also, there is a role of multidisciplinary teams, precision. There is a role of precision medicine and precision diagnostics, and NGS testing, etc., to find the mutations and abnormalities in patients' genome, and then target appropriately to give them the best benefit. These all are very, very important things. PIK3, ESR1, these all can be abnormalities or abnormal mutations, which can lead to therapeutic relevance, and we need to really target them appropriately and different time frames. There are a couple of studies which have been discussed, and there are a couple of molecules which have been discussed, and the guidelines made based on all these things: CDK4 inhibitors, aromatase inhibitors, tamoxifen, Capivasertib, Elacestrant, Toremifene, so on and so forth. There were molecules which are in endocrine therapy armamentarium. While at a similar time for HER2 positive disease, the buzz about ADCs is there. Again, one has to be carefully seeing that, what is the potential toxicities and management of those, barring that ADCs really, was the center point for discussion, because they have shown that in the first line setting, with DASNIO9 data, they have shown that they can take the first line setting, they can be effective in second line setting, they can be in later line setting, depending on when and how, what drug was offered, and what is the context. And also even HER2 low disease, they have shown a promise. So that was really, really important, but one has to be very carefully choosing that what could be the potential toxicity, especially the interstitial lung disease, nausea, vomiting, etc., were discussed very carefully and elaborately. About the triple negative space, also, again, the antibody drug conjugates like Sacituzumab or Dato-DXd, they both were discussed. What the data suggests, how can we judiciously use them, what would be the potential toxicity, all those were discussed. And these were the newer, things which are coming into advanced breast cancer patients. Armamentarium, extending the armamentarium is a good news, but again, we have to be careful, watching for toxicities, managing them, and also the financial toxicities, because ultimately the goal is that these drugs should reach to every potential patient. So with this, I would say that the motto was that, we need to join hands, and everybody is important. This is the teamwork wherein the patient, caregiver, patient advocates, researchers, clinicians, everybody together, when they join hands, they can make a difference in advanced breast cancer patients' lives. And with this, I would end here. Thank you very much.